and I'm going to discuss about severe community-acquired pneumonia for strategies for effective treatment. We are more than 70 people online, and this lecture is going to be recorded, so I hope that it will reach even more people. So these are my conflicts of interest for industry and for academia, as Helen has introduced before. So I serve as the chair for the Critical Care Group at the European Respiratory Society and the chair for research in the European Society of Intensive Care Medicine. This is a sponsored lecture by Biomarker-aided. However, as you can see, I have different conflicts of interest, but the most important conflict of interest is the management of my patient. And I'm going to share with you my experience in this regard. The first is because why we are going to talk about community-acquired pneumonia, more especially why severe CAP. And I think that severe CAP is that one that is for patients that they are admitted to the ICU. That is for sure that some patients, depending on the ICU capacity, might not be in ICU, but for sure those that they are in ICU, they are going to carry the highest mortality. But when we are looking at which is the highest mortality, because in this graph, taking into account different works, we can see that it can reach up to 40%. And this 40% comes from different studies. I'm just showing one study from Barcelona that showed when we analyzed patients that they are with the presence of septic shock and the need of invasive mechanical ventilation, is when you have this number of 40%. And these are, as I mentioned before, patients that they are being admitted to the ICU. There are different guidelines that they have been trying to attempt to guide the management of patients with community-acquired pneumonia. These are the last guidelines that they were published under the American Thoracic Society and Infectious Disease Society of America in 2019. But these guidelines, unfortunately, they are just for everything. So they are not for patients that they are with severe community-acquired pneumonia. They are for patients that they have from out of hospital to in hospital to ICU community-acquired pneumonia. So for this reason, with different colleagues, we consider that it was very, very helpful and very important to guide the management of these patients that they are in very severe conditions. You can see that these guidelines, they were published by two major journals, the European Respiratory Journal and the Intensive Care Medicine Journal. A part of the respiratory and the intensive care medicine societies, also clinical microbiology and infectious diseases from Europe and the Latin American Society endorse these guidelines. I'm going to follow these 5 points over the next few minutes in order to summarize which is the evidence for the management of pneumonia based on the guidelines. So the first is diagnosis. And we all know that strep pneumo is the #1 pathogen in patients with community-acquired pneumonia. That is true that we have other type of pathogens such as Legionella, Staph aureus, even Pseudomonas, and in less number of circumstances, polymicrobial. However, we have seen that also when we have patients with viral infection, especially patients with influenza, we can have a high rate of co-infection that it go up to 50% of the patients. And also what we have seen is that the number of cases with co-infection is rising every year. And we are having some pathogens that they were not common as co-infection, like for instance, Aspergillus. With this the square in red, I'm not trying to scare you that Aspergillus is a common pathogen, but I think that we have to consider that co-infection is a major burden in patients with severe community-acquired pneumonia due to a viral infection. However, I could say that probably one of the most important parts in diagnosis is the lack of diagnosis. This is a paper that was published in 2012 in Thorax from a German group that included over almost 50 studies. And you can see that the most common pathogen is having no pathogen, so having unknown. That is true that this paper is more than 10 years apart. However, this paper was published only a couple of years ago, and what we can see in this paper that was done with different colleagues in different parts of the world, we can see that the etiology was only found in 30% of the patients. So in this study, we wanted to analyze not only immunocompetent patients, but also immunocompromised. And you can see that the detection, even in patients immunocompetent, is even lower. So we have a big problem. And that is true that we have seen that there are molecular testing. Here in this slide, you can see the possibilities of different PCRs that they are available in the market. And also, I would say that in this paper that was published also last year, we did an effort to summarize which is the current evidence about molecular testing. And what we can see is that we have had an important number of companies that they are pushing towards getting multiple real-time PCR. This is something extremely important because we can adjust the diagnosis and we can also adjust the treatment. That is true that we have two ways. We can use a way that is based on non-invasive methods, such as endotracheal aspirates, or those that they are more into invasive methods. Obviously, the more invasive, the more specificity. With those patients that we are using non-invasive methods, that we are using endotracheal aspirate or even sputum, we have to be careful that we are not analyzing the wrong sample, that we have an adequate quality in order to process that sample and not throwing away that very precious tool. Also, we have seen some experience from this type of test. I'm just showing this study that was done in Greece from the group of Giamarellos, and we can see that if you remember those numbers that I showed before in 2012 and even last year, we can see that with no molecular methods, the detection was very poor. However, here in this slide, we can see that using the film array pneumonia panel, the detection was decreased of unknown in only 30% of the patients. That is true that we have some bacterial and viral co-detection. So that is helping us in order to do an adequate treatment. We need to also consider that the number of respiratory viruses is rising. We have seen many different viruses surround us, and we have seen in the pandemic the presence of COVID-19, and over the last years, obviously influenza, parainfluenza, but more often RSV, metapneumovirus, or even rhinoviruses. When we are analyzing this type of panels, this is a very nice study that is comparing the use of a multi-test bundle that it was using nasal PCR plus the typical way that we use in clinical practice, using sputum, blood cultures, and antigens in urine, compared to the use of the pneumonia panel. You can see that the detection is much higher when we are using these multiple PCRs. We have other tools that they are also being done in blood cultures. And we can see that these type of tools are very helpful in patients with sepsis, because you can compare the difference based on a standard and rapid methods, where we are going to get a much faster approach in order to de-escalate or to give target antimicrobial therapy. These are the different targets that we have that is going to provide a very high sensitivity and specificity. There are also some experiments. This is a very nice experiment showing the utility of film array in blood cultures in critically ill septic patients. And what we can see is from those patients that they have a positive impact, so they are positive, this study showed that the antibiotics were adequately escalated. And interestingly, in up to 10%, they were de-escalated almost immediately. We have a couple of experiences from other parts of the world. This is a study from Japan that is showing a post-intervention study, including the use of film array in patients with bacteremia. And you can see that there are two positive things, de-escalation and the time to onset of vancomycin, a part of the benefit survival. There is another study from the Mayo Clinic that you can see that the use of this test when included in teams, and this is the magic bullet, because in this study we can see that when it was included in antibiotic stewardship teams, there is no difference in detection, but there is a very important difference in de-escalation. So that reinforces the point that this type of test, they are not just tools, they are also tools that they can modify the clinical management. For that reason, when we are looking at the guidelines, we suggest to use this molecular testing, multiple PCR testing, in order to adequately prescribe antibiotics. The evidence comes from many studies. Here you can see that included 28 observational studies with one systematic review, and it was highly associated with an incremental detection rate and a PCR detection rate. In this case, I'm summarizing the studies that they were associated with Staph aureus. And as you can see, I think that this is a very graphic design of how things are in ordinary testing. So you can see that we are going to have the results or the strategy within 96 hours compared to a PCR that could be as fast as in few hours. We are going to move to biomarkers. In biomarkers, it is important to consider that we have these 5 points that they have a bit of a marketing, but I would say that they are important when we are going to choose the biomarker. Sensitive and specific, measurable. We need to know what we are measuring. It needs to be available and affordable. And when we are talking about affordable, it's not only the direct price, but also the indirect price about how it's going to work. That is going to be responsive. That is important when we are looking at the way that we are analyzing the biomarker, that is timely. And we are going to show some examples. The first is that when we were looking at the best standard of care, many of these studies, they were done with a very high number of control days. This is obviously not appropriate in 2025 to have a patient with a non-ICU community-acquired pneumonia being treated for almost 2 weeks. Also, we have some examples of using other biomarkers. This is the example of the use of C-reactive protein. However, you can see that despite the median is significant, the number of days in duration of antibiotic therapy is exactly the same. You can see that it's 7 to 7 days with some differences when we are looking at the mean. However, the de-escalation and the length of stay, mortality, and MDR pathogen detection was exactly the same. For that reason, we wanted to introduce the use of procalcitonin to reduce duration of therapy in order to detect how it's going to improve outcomes compared to non-using serial biomarkers. And I would like to highlight that is serial. It's not just one sample. This is a study that I published some years ago that you can see the correlation of PCT with treatment failure. Obviously, we need to take into account the differences in terms of the cutoff, because as you can see in this study, the cutoff is going to change the sensitivity depending on the type of severity of the patient. Equally, you can see in this international expert consensus that in patients with ICU, the cutoff for procalcitonin is much higher than in those patients that they are outside of the ICU. When we are talking about a stratification of severity, we need to make us several questions. Is this patient at risk for a severe presentation? Is this patient infected? Is this patient being cured? Or is having a refractory infection despite of antibiotics? We have to also consider that when we are looking at community-acquired pneumonia, and just to put an example of different scores, this is the CORP score, is going to take into account, again, very different organ failures. So because remember that pneumonia is a systemic disease. For that reason, we need to evaluate which are the criteria that they are going to help us to detect those patients that they are going to have the highest mortality. For that reason, I put here this study that was showing, when analyzing all the minor criteria, that the presence of bilateral infiltrates and using alveolar and interstitial as those that they have the highest odds ratio, so is associated with the highest mortality in patients with severe community-acquired pneumonia. In terms of antibiotic treatment, I think that in this we were quite straightforward. We suggest the use of beta-lactams, third-generation cephalosporin, with the addition of a macrolide instead of a quinolone. The evidence is quite numerous. You can see here that there are many studies showing a benefit of the use of macrolides against fluoroquinolones when we analyze all of these studies. Also, the use of macrolides is not going to be only beneficial in patients with comorbid conditions, but probably more in those that they are not having comorbid conditions. So those that they are not going to have resistant strains and they are going to have less comorbid conditions, as you can see in this machine learning study. Again, we have an indirect evidence when we are looking at which is the best macrolide. In this case, based on this study from a Greek group, the use of clarithromycin represents a benefit compared to others. And we also need to consider which are the risk factors for those patients that they are going to develop an NDR, because there are some guidelines that they are recommending the use of an anti-pseudomonal beta-lactams. We can take into account different risk factors. However, many of them, they are going to be very heterogeneous. For that reason, in the guidelines, we wanted to include different scores, like for instance, those scores that they are going to help us to detect the presence of NDR. And the most important is how many patients are going to have these local issues depending on the country that you are practicing. There are different drugs, as I mentioned before, third-generation cephalosporins, but also there are new drugs that have been launched over the last few years. I could say that probably the ones that they are more relevant for critically ill patients are the first one, ceftaroline, because of the benefit in MRSA and strep pneumo with high MICs, and the second, ceftobiprole, with the presence of gram-negative pathogens, including Pseudomonas and Enterobacterales, ESBL negative. And there are others that I think that there are some studies showing a benefit, but probably they don't have many of these patients being admitted to ICU, as we have seen some papers published with macrolides, like for instance, solithromycin, or even the new development of new quinolones, including the laflaxocin that has had some papers coming in very important journals like the New England Journal of Medicine. And the last part is about coadjuvant treatments. And I think that these coadjuvant treatments is mainly two, but I could say that in the guidelines, we were looking for the first one. So these two were corticosteroids and immunoglobulins. And as I mentioned, we wanted to assess the evidence for corticosteroids. In the American guidelines, when you look at the questions, among the 16 that they evaluated, they took only one for this area of corticosteroids. And what we can see is that there is no recommendation in favor in patients with both non-severe and severe CAP. Some clarifications arrived showing that only in patients with acute exacerbation of COPD. However, some studies were showing that there were some benefits, especially this study that I'm going to talk to you in a second. And then the editors of the guidelines, they were more open to consider the use of steroids. This is the reason that we wanted to analyze the evidence, because when we wrote the guidelines, we had pretty much the same amount of papers that the American guidelines they could analyze. And for that reason, we saw that in COVID, we had an increasing amount of evidence, and in community-acquired pneumonia, we could see different authors that they were including the use of prednisone, methylprednisone, or dexamethasone. That is true that even in COVID, that we have seen a benefit, a late administration of corticosteroids was not associated to a benefit. So we need to give them early. The evidence in the guidelines is coming from these pool data. And as you can see, the benefit comes in patients that they are in shock. However, we can see that at the time that we published the guidelines, two major studies were published. The first was published in the US, that was including patients that they were mainly veterans. So those patients that they were with some age, and in this case, they were analyzing methylprednisolone. The issue is that the number of days was quite long, and there was no benefit in terms of survival. There was another study that was performed in France that was a double-blind, a parallel study from Deakin that was using hydrocortisone, and in this case, they had a benefit in terms of mortality. We wanted to be sure that what we recommended was adequate, so we repeated all the evidence, and what we found is that, again, the use of steroids was beneficial in patients with shock. So for the moment, the guidelines remain in terms of corticosteroids in patients with CAP, but for sure in patients with septic shock. There is no benefit with treatment failure, so that is the reason that it is not for everyone. And when we are looking at the different studies, and when we are comparing different drugs, dexamethasone, hydrocortisone, methylpred, and prednisone, we can see that the hydrocortisone is the winner, because when we pull all the data, it has the best performance in terms of all-cause mortality, duration of the need of invasive mechanical ventilation, presence of ARDS, septic shock, and length of stay. For that reason, there are some editorials that they are recommending what we said in the guidelines. However, they suggest to use it quite early in some particular patients. I am particularly not in agreement because there is no evidence so far for these particular patients. So I think that we need to have more studies to conclude that what was discovered and what was published is right. Also, we have seen that there are some animal studies. This is a study that we performed in Barcelona. And as you can see, there is an added evidence that the use of both corticosteroid corticosteroids plus macrolides was associated to a decreased concentration of strep pneumo, decreased percentage of colonized lungs, and inflammation manifested by the ATS lung injury score. So what we can see is that there is less inflammation in all the items. But when we are talking about coadjuvant treatment, remember that no treatment is definitely not adequate, but the use of both adequate therapy plus support has an added or assumptive evidence, as we are using antibiotics alone and support alone, because we need more than just antibiotics. This is the reason that opens up for the need of personalized medicine. We can see that in this study, the use of immunoglobulins was not associated to a benefit in terms of patients with severe community-acquired pneumonia. However, what we discovered is that there was a benefit in patients that they had a low level of organ failure. So there was a discrimination in terms of immunoglobulins. And this is the reason that when we apply this concept to the data that was showing no benefits, so we can see that those patients that they are with high inflammation manifested by a high CRP, or they have a low immunoglobulin levels, we had a benefit from that no difference in between patients. So we had 36 versus 11, so a very impressive difference. So I'm finishing with some questions that everyone has to do when we are talking about antibiotic decision making. I think that this is important because we are in a world with more and more resistance, more and more detection of infections that they are very difficult to treat. And for that reason, we need to have tools in order to decrease antibiotic duration when we can stop or narrow the therapy and when we can decrease the duration. So thank you very much for having been here. This is just the evidence of the guidelines that they were published. I mentioned or I covered the majority of the points. However, there are some, especially related to the use of invasive mechanical ventilation or high flow, and also the use of antivirals in patients with influenza that you can get into the guidelines. They are in open access, and you can get more information about what I said. These are the co-authors that they were involved in the guidelines that I am obviously very pleased to have them having this important document. And I'm finishing here, and I'm very pleased to have any questions that they could be sent to me. And thank you very much.
Thank you, Professor Martin-Loeches, for that very insightful and informative lecture. I am certain that we, your audience, have gained very much valuable knowledge that will enhance our day-to-day practice as clinicians and microbiologists. We truly appreciate the opportunity to learn from your expertise. To further enrich our discussion, we would now like to open the floor for a 15-minute Q&A session. To the audience, please feel free to either send in your messages through private chat, or if you can put it in the Q&A box, it would be more appreciated. And we will try to address as many as we can. Professor, for our first question, there is a question that says, in the first part of your talk, you discussed the standard versus rapid multiplex PCR identification in blood culture. Can you try to elaborate on how this rapid multiplex PCR testing can facilitate early de-escalation of broad-spectrum antibiotics in terms of sepsis management, and in terms of, for example, you also mentioned about some severe pneumonia patients having Aspergillus detected, in terms of doing this rapid multiplex PCR testing in detection of fungal infection or fungal fungemia?
Yeah, thank you very much. I think that we need to to make a difference or to share a difference in terms of management of patients that they are using blood cultures or a pneumonia panel. We are going to start with the first, that is related to blood cultures. I think that we have in many cases many patients that they are obviously having fever, but they are not in septic shock. And in these patients, it's quite common that we are very unsure which is the best treatment. And in this case, what we do is we can send a sample, we can get some results at the time that, because we are going to have the results within a couple of hours. And if the patient is not showing septic shock, that we can do is hold and continue. Obviously, this is not the same if we have a patient in septic shock. If we have a patient in septic shock, we need to do as we do as usual. So trying to see that there is a source of infection. Obviously, a common source of infection could be a line sepsis. However, we need to consider that that line might be inserted not many days ago. So for that reason, we need to look for other sources. And if the patient is in severe condition, the test is going to help me to probably to get target treatment. So for instance, we have a patient that we are starting in septic shock, vancomycin, maybe a carbapenem plus aminoglycoside, and we get the result that we have an Staph aureus. In that case, we can rapidly de-escalate and to stop the gram-negative agents. Vice versa could happen with gram-negatives. We have seen that is true, that we have less and less MRSA in Europe. However, we have more and more vancomycin-resistant enterococcus because we have an overuse of vancomycin. So this molecular testing is going to help us to de-escalate quite rapid the use of vancomycin. When we are talking about the respiratory test, is a different approach. I think that we need also to be sure that we are using a good sample. I introduced this concept when I was giving my lecture. It is important, and I had some questions from different people of some positive results in sputum. The majority of these sputums are not adequately processed. So we are talking about the sputum that does not have adequate epithelial cell count. So we are just treating colonization. For that reason, we need to have a good sample. This is the reason that I would like to also emphasize that we need to have a multidisciplinary approach, not just to have a machine in an ICU or in the emergency department, but a combination of work with clinical microbiologists and clinicians, and also infectious diseases all together in order to get the best interpretation of the results. Because sometimes we can get into treating things that they are not adequate because the sample was not adequate. Obviously, that could happen with conventional cultures. This is not unique of molecular cultures, but obviously, because we are going to get faster, we can have some results that they could trigger to overtreat. So for that reason, I think that this is important. So as a bit of a summary, I think that we need to distinguish if the patient is in a very, very severe condition, if the patient is in septic shock, the patient is with multi-organ failure, or the patient is not. One of the things that we have learned, especially with molecular testing, is that we were overusing antibiotics in many occasions. And this type of testing is helping us to take a bit of time in order to not to hit hard when the patient is not in a very severe condition, because otherwise we are going to overuse antibiotics. So we have a huge responsibility, and we have better tools that they are going to help us to be more mindful in order to treat our patients.
Thank you, Professor. I think that's quite clear. One of the key points I got there is that there's really a strong need to establish a multidisciplinary approach in order to optimize patient care. Next question, Professor. In cases of community-acquired pneumonia with suspected co-infections, how can this kind of innovative testing, especially when used with the biomarkers that you also discussed, assist in differentiating viral from bacterial causes, and how should this influence antimicrobial stewardship strategies?
Okay, so this is a very good question, and it's a common headache for many clinicians. I think that we need to distinguish well the type of viral infection that we have. I'm going just to put a common example. I mentioned about influenza. In influenza, we had up to 30, 40, even 50% of the cases a co-infection. This co-infection can happen. The first one is going to be an strep pneumo. Sometimes we have a Staph aureus, and then we can have some other type of pathogens. When we are looking at COVID, that was not the reality. In COVID, we saw that the presence of co-infection was pretty much anecdotal. And that is the reason that with the use of molecular testing and with our knowledge that we could not find co-infection, we were using shorter terms of antibiotics. That is true that when the patient comes to the ICU in a severe condition and with when we don't know, we are going to hit hard. But if we can get a sample, we can exclude that we have a bacterial infection. We can analyze, as I mentioned before, in a multidisciplinary way, not just with the molecular testing, but also to check the type of organ failure. Like the patient is not in septic shock, maybe it's a single organ failure, so it's just hypoxemia. Or the patient is having a low PCT, so we can determine that we can reduce the use of antibiotics. As I mentioned, there is no one single magic answer. I think that we need to integrate together how we are going to discuss this again amongst the different members of the team.
Thank you, Professor. The next question moves back again into bacteremia bloodstream infection. It says, in resource-limited settings where traditional blood culture techniques may have prolonged turnaround times, what are the key advantages and limitations of using marker genes for antimicrobial resistance in terms of optimizing patient management?
Well, this is again a very good question, and I could say that it does not differentiate from middle and lower income countries compared to high income countries. I think that is for sure much cheaper and adequate diagnosis than a very expensive antibiotic. And this is a huge responsibility when we are treating a patient. So this is something that I say always to my registrars, that if you have a patient with a high blood sugar and we are using insulin, or we have a patient with hypotension and we are using norepinephrine, this treatment is going to be affecting only to that only patient. However, when we are using one antibiotic, you are not only treating that patient, but you are also treating the environment, you are treating the neighbor. So for that reason, obviously, we need to have the best. And we would say, well, but this is expensive, but we need to only do the numbers about which is the benefit when we are going to integrate together the number of antibiotics that we are going to decrease, we are going to not prolong, and that is going to impact in the whole ICU. So as I mentioned before, I think that we have had a good experience with the use of vancomycin over the last years. We have seen that we have less Staph aureus, but we have a high increment of VRE. So with the use of this molecular testing, we can reduce the administration of vancomycin, and then, therefore, we are going to decrease the incidence of VRE. But things cannot be done out of the blue. They need to be done with adequate tools. So it's not easy to change clinical practice if we are doing again with the same tools that we had 20 years ago. So for that reason, we need to invest in this type of testing. This is the reason that, as you can see, that was our first recommendation in the guidelines, because we wanted to give a strong message. Sometimes when we are going to discuss with our administrators in not only the hospital, but as a local or even a government level, they are going to look at what guidelines are saying. And this is the reason that we wanted in the guidelines to analyze the literature in order to give a very straightforward answer. Like, yes, you should invest because guidelines are supporting the use. And we hope that this recommendation is helping people to negotiate better with administrators because they are in an office and we are in front of the patient. So we need to have tools. We need to get good evidence and good tools to treat our patients.
Thank you, Professor. I think that's a very clear message. There's a strong evidence, as you mentioned, it's really stated in the guidelines. And this kind of diagnostic testing would aid in terms of clinical decision-making, despite the perceived huge cost. But in the end, it's really optimizing patient care. A follow-up question to the previous question regarding community-acquired pneumonia, Professor. There's a question from, I'm not sure if this is Dr. Jobit Cruz, or regarding procalcitonin after the initial result, when do we need to repeat the test?
That is, again, a very good question. So we didn't want to make a recommendation about a particular number of days. So what we said is that we wanted to incorporate, as we said, a sequential assessment. So what we do is we assess again in an integral approach how the patient is doing. Like, for instance, if your patient is doing well, by day 5, 6, 7, the patient is having no fever, the oxygenation is improved, the patient is not requiring vasopressors, and you even have an improvement of oxygenation, you don't need to do a procalcitonin. The thing is that if you have a patient that is in this gray zone, that is having low degree temperature, you can see some signs and symptoms of, stability, or at least not this improvement, then you are going to send a sample by day 4, 3, 4, and then you are going to repeat the sample at day 6, 5, 6, 7, and then you are going to assess if there is a change in the delta of the concentration of the PCT. Also, the PCT, we consider that is a very good marker of how the patient can be de-escalated at the end of treatment. Sometimes we are dealing, as I mentioned before, with patients that they are critically ill, patients that they are in severe conditions, and sometimes it's not easy to make a decision when the patient is still under mechanical ventilation, still with a very bad X-ray, and you don't know for how long you are going to prolong. What we have learned from the past is that prolonged administration of antibiotics, not only in CAP, but also in hospital-acquired pneumonia and in BIP, is not going to be only, is not going to be better. It's going to be even worse because you are going to trigger more resistance. So for that reason, the use of these tools, and I, again, would like to emphasize the word tools, they are helping you to make a decision, but they would never substitute the way that you are treating your patients. So I think that the clinical pattern is the important one, and these tools are going to help you to be more solid, not only yourself, but also the team are going to share a common language, and they are going to be more reliable in the decision making.
Thank you very much, Professor. In the interest of time, one last question. Together with what you just mentioned and with one of your slides that discussed on individualized treatment, I find it very particularly impactful. Can you please elaborate on how choosing the right diagnostic test and the right antimicrobial at the right time can optimize patient outcomes in pneumonia patients or even in sepsis management?
Well, I think that the area of personalized medicine is a very evolving area. I think that I am very jealous of other disciplines, like for instance, in the area of cancer. Nobody could say you have a cancer. You could say, I have a cancer from that particular organ, with that particular marker, with that particular gene. So all of this is making the therapy to be, again, personalized. So for that reason, I think that in sepsis, we know that we are going to get more information with better tools in order to personalize the approach. And I think that, as I mentioned before, it's not only one thing. It's not just to say the use of this molecular testing or the use of this biomarker or the use of this antibiotic. I think that we need to incorporate all together. Again, there are some particular factors that we cannot forget. It's not the same, the treatment and the response to treatment that a patient with an age is going to have compared to another age. Again, that could happen in patients that they might have, for instance, some structural lung damage before the admission to the hospital. So this is particularly beneficial when we are using biomarkers. This is not just the topic of this lecture, but in the hospital-acquired pneumonia and ventilator-associated pneumonia guidelines, we recommended against the routinary use of procalcitonin in all the patients. But what we said was that if we had to prolong the treatment, like for instance, you have a patient that you have started with the wrong antibiotics, the patient has a structural lung damage, or the patient is developing treatment failure, and you are going to prolong the treatment, you should incorporate the use of procalcitonin. This is the reason that when I'm talking about personalized, we need to get the figure from different angles. It's not just to say, I'm going just to look at the patient from this side, but looking at the patient as a circle from very different angles in order to get the more information, the better, in order to make a more personalized approach. That could be also interesting when we are, as you know, the question comes for the type of treatment. I mentioned before, we recommended the use of third-generation cephalosporins plus a macrolide, but there are some patients where you are sending the sample, you might have a high MIC for that strep pneumo, or you might have even an MRSA, and then you need to adequately treat, and depending on the country, if you have patients from the community with a high number of MRSA, you might need to adjust your treatment. This is something that it is a very common problem in Europe. We know that the northern countries, so Scandinavian countries, they have very low resistance. So for that reason, for them, it's not a problem. But when we are looking at the south, we are going to have high MICs in patients with a strep pneumo. For that reason, that is the benefit of the use of ceftaroline, for instance, or even if you are suspecting that you might have MRSA, the personalized approach is going to be more related to the use of linezolid. Also, we need to consider that still there are some tools that they need to be considered. As I mentioned in the guidelines, we suggest to get a colonization in patients that they might have MRSA. So now we have patients that they might be called frequent flyers, that we are going to flag them as they have been colonized with MRSA. So that is helping us again for personalized treatment.
Thank you. Before we close the session, Professor, can you share some final messages or key takeaway from today's discussion?
Could you repeat again? I didn't.
Before we close the session, Professor, may we ask you for some final thoughts or key takeaways for today's discussion?
Thank you, Helen. Well, I would say that, first of all, I would like to say thank you to everyone. I think that is a very impressive number to have almost 100 participants. So I think that is not related to the speaker. I think that is related to the topic. I think that the topic is a very interesting topic for many of us. We know that we are also talking about community-acquired pneumonia, and we are in a spring in the majority of the countries that we are here. So that means that it's an area that we are all worried, and we all want to learn, and we all want to share our experiences. Obviously, what I try to do is in a humble way to try to share my experience. I'm not going to have the absolute truth, but obviously I wanted to share, you know, some of my personal reflection of science, because obviously things they need to have been supported by science and supported by evidence. And this is important when we are trying to treat our patients. So this type of sentences of, I think, I strongly believe, they should be excluded in clinical decisions. We need to consider where the science is supporting or not supporting. And I think that I tried in this lecture to highlight the areas where science is robust. And there are other areas where we don't have still answers, and we might need to wait a few years, or we might need to have more studies in order to give more robust recommendations. But obviously, I think that the webinar represents that we need to be updated. We need to know what's going on. We need to learn. And this is our responsibility because it's in our patients' lives.
Once again, thank you. Guru Maagot, I hope I got that right, Professor Martin-Loeches, for sharing your invaluable expertise with us today. Your insights into the complexities of managing severe community-acquired pneumonia and sepsis, the evolving treatment strategies, and the critical role of timely and accurate diagnostics have been truly enlightening. With that, and on behalf of Biomiru, I extend my deepest gratitude to you and to all of our audience for your participation. Let's continue to embrace innovations that enhance patient care and drive better healthcare outcomes. Thank you, and we look forward to seeing you at our next session.
Thank you.